committee meeting to order. Stand for our invocation. Josh, can you lead us, please?
Dear Heavenly Father, we thank you for this day, Lord. We thank you for bringing each and every one of us here, Lord. We ask that you guide and direct our meeting today, Lord, and ask that each one of us make the decisions for our tribe and for our people based on what you would like us to do, Lord. We thank you and ask you to please bless us and keep watching over us as we go on our ways out. In Jesus' name, amen.
Amen. Shelley, roll call, please.
Yes, sir. Mike Dobbins.
Here.
Dora Petzkowski.
Here.
Keith Austin.
Here.
Danny Callison.
Here.
Julia Coates. Sean Crittenden. Joe Deere.
Aye.
Rex Jordan. Johnny Kidwell.
Here.
Daryl Legg.
Here.
Wes Snowfire. Joshua Sam.
Here.
Mike Shambaugh.
Here.
Melvina Shotpouch. E.O. Smith.
Here.
Condessa Teehee. Victoria Vasquez. We have a quorum.
Thank you, Shelley. Hope you've had a chance to look at the minutes. If so, I'd entertain a motion to approve. Second. All those in favor? Aye. Any opposed? Motion passes. Time for reports for Mr. George Vallier. Thank you, George, for coming.
You have a copy of my report in your packet, I do believe. For the month of March, we did 996 COVID tests with 46 of those positive. Just last week, we did 182 tests with only 16 of those positive. For the month of March, we had 147 contacts in audiology, 416 through the diabetic clinic. Physical therapy saw 157 patients. Our visits are up and collections were good. We collected just over $4 million that month. Any questions? I added the appeals onto my main report. Any questions?
Any questions for George? Appreciate the report, George. I'm just gonna, on page 1 of your report, you mention all the COVID-19 positive case breakdown there by ages, and then the positivity rate 4.6%. So does that mean only 4.6% those tested were positive then?
That's correct.
Okay. At the height of the pandemic, what was your positivity rate? You remember, just roughly?
Oh, we were up around 20%, 15 to 20.
Mm-hmm. Okay, so good news there. I just wanted to ask one question on, you listed the 473 patient visits seen by dental in March. How many are on staff there at the Claremore, on dental staff?
I think we have four dentists. I'll have to double check.
Okay.
4 dentists and 10 or 11 assistants and 2 hygienists.
Okay. Do you have any specialists on staff there?
We have 1 oral surgeon and 1 pediatric dentist.
Okay, all right. So 473 patient visits seen by dental for the whole month, is that correct?
That's correct.
So roughly 23 work days in March, that would mean 21 patient visits a day. Is that accurate with that staff you have? Going to have 21 patient visits?
I believe so.
21 patient visits, and you have 4 dentists, 2 specialists, hygienists.
I believe. I'm gonna have to double check that when I get back.
Okay, yeah. Yeah, because just on average,
Sure.
there'd be 21 patient visits a day, and you've got a pretty healthy staff, right? Just asking.
Yes, I agree.
Okay.
Let me double check that when I
Okay.
get back.
All right, we'll let it go at that. Any other questions for George? Johnny?
Thank you, Chair. I don't have a question. I just want to say thank you for adding the appeals onto your report. I appreciate that.
It's all my pleasure.
Might stay around too, George, because we're going to just briefly cover contract health.
Okay.
And, certainly Claremore Indian Hospital has a part in our contract health.
No problem.
Keith?
On your appeals report, George, I know that appeals can be a multi-stage process. Does this take that into account? When that says denied, does that mean it's final denial? No more
No, these are the
possible?
appeals that came through us. There's a third appeal that goes to area office, and I don't have a count of those.
Okay, so we don't know if of the 13 that were denied in this report, if some of them may have got approval at that final stage.
They may have.
Okay. You know one? Well, I know it does happen quite frequently. Okay, well, that's the information we just don't have available. Thank you.
Any other question? Mike?
Yeah, George, what, on the denied, is there one particular thing that gets most people denied? Is it lack of money, or is it something else? Do you
No.
run out of money, or?
No, it's
what?
not a lack of money. The physicians who review those are the ones, what they do is they prioritize those for payment. And then, well, I guess it would be lack of money, because then we start paying, we have an allowance every week so that we don't run out at the end of the year. And based on those priorities set by the physicians, they pay until they run out of money.
Now, I know at one time, because of COVID, we were under serious or life-threatening or disease-based only. I mean, like something like a rotator cuff tear, knee messed up. We weren't doing that for the longest time because of COVID. Are we back? Are we still in that mode, or are we fixing the lesser injuries now? Or are we still in major issue mode?
We've always tried to pick up orthopedics. Now, we don't do joint replacements, but your rotator cuff tears and things like that, fractures, they come off the top.
Okay. All right. Thank you, George.
Yes, sir.
Danny?
George, when someone gets a denial, is that explained on the denial of why they're being denied, so that your basic common folk could understand exactly why they're not getting denied, they're not getting treatment?
Probably not. There are certain, I think I stated in here last month that we tried to change that letter and make it more understandable. We were told in no uncertain terms we were never to change that letter. I went back and we talked to the PRC staff, and they came up with an information sheet that better explains the denials and deferral reasons, and we can't change the letter, but we can we put that as an attachment when we mail those out. So not only will they get the official IHS letter, they will get another page attached to that hopefully helps explain that.
So when it is denied, who I realize we probably can't help every person. How do we choose which ones we help and which ones we don't help?
The docs, there's a group of doctors that sit and prioritize all those referrals.
Thank you.
Just a quick follow-up. On that attachment, what would that say? I mean, does it actually tell you why you're denied? I mean, in black and white terms, or?
I'll bring it down here next month.
Okay, that'd be great.
And that way you guys can see it.
Okay.
Be happy to.
All right, thanks, sir.
That's what I was going to ask for, is if we could have a copy of that.
I don't have one with me, ma'am, but I'll have one next time.
Okay, thank you, thank you.
Sean?
Yeah. Are we talking the attachment, is that for the same as Cherokee Nation Health? The attachment that you're talking about?
No, ours would be different than the one that you guys sent.
All right, thank you.
Any other questions for George? Thank you, George.
Thank
You
you.
could stay in the event we have any other contract health questions. Thank you. Okay, Dr. Stephen Jones is here from Executive Director of Cherokee Health Services.
So I'll turn that on. Good afternoon. All right. I'll go ahead and go through the report real quick, and then we'll get to the questions if that's pleases the chair. What you have on your report, some of the things we talk about every time is the contract health or purchase preferred care, and on this month, we were at 96% approval rate. The vacancy rate was a little higher this time. Part of that is because we've started opening up all the positions for the construction projects that we have across the clinics, and so they show up on the vacancy report because we've just started recruiting for those. And then this time of year, some people are finishing up their commitments and will be changing out or moving on after they finish their scholarship commitments with us. So I wanted to talk and thank you guys at council, the ones that attended for our Provider Service Awards. That was fantastic support, and I think our providers really appreciate you guys showing up and being able to visit with you. We had great attendance this time. We haven't been able to do that in several years, and so it was a chance for them to network with one another and do something outside of work to have a little time to blow some steam off. We did recognize 2 Lifetime Achievement Awards for Dr. Doug Nolan for 20 years of service and Dr. Dante Perez for 27 years of service. Dr. Nolan, as you know, has moved on to work with OSU Medical School, and Dr. Perez has recently retired, but he's coming back to work for us PRN, so he's still going to keep his hands in our system, and we appreciate that. He works very well with the residents, and we're getting ready to start a new pediatric residency in July, and he's going to be very integral into that development of that program. So again, thank you all for your attendance. I did pass out before the meeting a newsletter. I sent it to, I believe it's sent to Shelley or to Gail to send it to you electronically, but I wanted to make sure you have a hard copy in your hand. I sent it out probably last month. This is a newsletter that we send out to all of our health employees. It just talks about some of the things that are going on in our health system, recognizing some individual achievement as well as departmental achievements. I will ask you to this comes out quarterly, so if you would look at page 5 when you get a chance to read those stories. We had a couple of employees that just went above and beyond during the pandemic and during when things weren't going so well that they took it upon themselves to initiate some care of individuals outside of someone coming into our clinic. So it was just nice stories and recognize them and let you guys know of all the good things going on in our health system. I know you don't always get to see that. You get to hear a lot of the things that maybe are challenges rather than the things that were accomplishments. So with that, I'll open it up to questions and
Questions for Dr. Jones? Darrell?
Steve, or Dr. Jones, on contract health, is there something we could do to help y'all? As far as, like, I got a bill from a procedure from June of 2020 last week. You know, it's like you just start about a year or two later after you think everything's all said and done, then diagnostics imaging might send you a bill, then somebody for the IVs that they put in, anesthesiologist might send you a bill separate. Is there any way that we could fix that? Because it ain't y'all sending us a bill, it's you know,
So with contract health or purchase referred care, we are the payer of last resort. So everything else has to be paid before the bill comes to us. And in that, there is a timely filing. So some of these providers are, in some of those cases, the timely filing is different on different insurances. So they're running at the very back end of that timely filing. So they may not have even submitted your bill to insurance or any other third party for 4 or 6 months from when your service occurred. And then at that point, when they're paid, if there's a secondary or something else, then the next process starts and that timeline starts over again. So that's why those are so backed up and so far behind, because we are the payer of last resort. So we don't get that till everything else is paid, and then whatever's left on the balance is what we take care of. Yeah. So that's what causes that delay a lot of times. And sometimes the providers we contract with have turnover, and they don't know to bypass the patient and come back to us. All they see is your name, and their standard process, as soon as they get that payment, is to send the bill to you instead of sending it to us. So we're constantly re-educating our contracted providers, because it's not the providers, it's their staff that has turnover. So that person that's doing that may be a new person since the last time we did that training. So that's where a lot of that confusion occurs.
and I'd like to brag on Steve Carey. He's, I know I'll wear him out, but man, he's a joy to work with, and he really works hard to take care of problems and issues we have on weekends. It don't matter. When I call, he always answers, and I appreciate him so much. Let him know.
Yeah, okay, we'll do that. Absolutely.
John?
Doctor, let's talking about the attachments. I know we talked last month, I believe, about a lot of that's, of course, IHS, federal policy, about what can be put in that. Do we have some sort of attachment that we put on there?
A letter that goes out, we do have a letter when someone is denied, and they can start through the denial process. And as he said, if a patient has a problem with that, then we will help them. We have people that will help them, patient advocates and such, that will help them get their appeals process filled out so that they know what other, things are needed. Sometimes it's simple as just an address or a correct phone number. There's a lot of things that go into that have to be all done and T's crossed and the I's dotted before the referral can be processed.
Now, well, I know a lot about Golden Corral, not medicine, but is there a place on there that we might be able to put denial doesn't necessarily mean that you're totally denied? Is there something that says that, Doc?
There is a part of that says, this is the appeals process, this is what you need to do if you want to appeal your claim. So that is in the letter that explains that to them. And part of the problem is not referrals that are driven from inside of our system, and I want to make sure everybody understands this. So if we send a person out to, let's say, a cardiologist, and that cardiologist says they want something else, another consult done, and they send that patient, well, that doesn't close the loop to come back through us to get that referral approved, because we didn't know they sent that person, even though we sent them to the first doc. So part of this challenge that we have is figuring out how to close that loop so that we can come back and approve that referral also. That referral takes place outside of our system, even though it's our patient getting treated, and we don't know about it until after the fact. And then we're caught trying to catch up rather than getting ahead of it. So we're working on a new system to try to fix that so that our providers stay, and we're trying to educate our providers that we send to that they need to let the primary care provider know that they're going to be asking for another consult or some other opinion, so that we can get that process initiated rather than be on the back end trying to catch up.
Right. And with the 90-something approval rate, really, you should be applauded.
Yeah, it's a very small amount, but it's
Right.
the ones that,
Right.
that small amount's the ones calling you.
And what I hear is, Shauna got denied, and I don't know if anybody else hears that, but their initial, when they get that letter, I got denied. Well,
Yeah.
no, well, I hate the word denied, but we got to use it. But we got to go through that appeal process, and I just.
Right. And sometimes, like I said, it's simply bringing us the paperwork from where that outside provider sent you to someone else, or let's say you went to the emergency room at another location, and that broke your arm or something, and they sent you to an orthopedic person. Well, that connection wasn't there. We didn't know they sent you to an orthopedic. All we got was the bill for the ER.
You bet.
So that's the piece that we're trying to figure out how to close that loop and make sure that we're starting that on the front end rather than catching it up on the
Well,
back
with
end.
that 90-something% approval rate, just, you guys are doing a great job. Appreciate it.
Thank you.
Danny?
Yeah, Dr. Jones, what would be a reason for a typical denial? I know, even though your forms are different than what they are at Claremore, they still don't explain to people why you're not going to treat them. And I have heard that we can't treat everybody. I've heard that it's a lifelong commitment, that we can't commit money for several years down the road. When we talk about taking care of somebody, it doesn't fall into the prelims of what we're supposed to do. So when you say that, who actually makes those decisions? Do you make those decisions or where? Because I have several denial letters and you print out exactly what the physicians ought to know because of the way things are today, and you write them out and you go from there, and you still get denial. It's not because you don't have an address or a paper. It's generally because they just will not do it.
There's actually rules that go along with contract health, and some things get denied maybe because you had a high-risk, say you're a rodeo. That's something that is high risk, considered not covered. If you got injured performing in a rodeo, that's not covered under contract health. So sometimes there's additional information that has to be gotten before we can approve those claims. If you show up in an ER, let's say, you go out and drive a race car on a dirt track on Saturday night and you're injured in a wreck. That's not covered under contract health. That's considered risky, above risky business or behavior. So those type of things are denied. Experimental treatments are not covered. So if you have some type of illness and you're wanting to do something that's off of the norm, that's typically not covered or isn't covered. So those would be denied. As I explained to Counselor Crittenden, if you've gone to an ER and ER referred you out, but the referral did not get back to us saying that he referred or they referred you to that another provider for orthopedics or whatever, we don't have record of that. So that's going to get denied until we get the records of that so that we can initiate the referral from our end. So those are some typical things that would be denied.
Is there any way that the council could get this piece of paper that tells what we don't cover and we do cover?
The rules of contract health?
Yes, sir.
Yeah, and as a matter of fact, we do that one-on-one or that orientation where Steve Carey, if you show up for the orientation that health gives, Steve Carey does a whole presentation and we'll visit with you one-on-one during that. And so I did speak with him. If you guys would like us to set that up and do that in a seminar format so that you can have some time with him to ask your questions and go through the basics of contract health, we'll be glad to set that up.
Mike, okay, go ahead, Johnny.
Well, thank you. Thank you, Mr. Chair. That's the idea of what is covered in this whole contract health thing. This is new to me. I sat through the initial, orientation. Great time. I mean, I learned a lot, and I truly appreciate that. What I don't remember is going over hey, if you're in a rodeo, that's not covered. But if if you weren't in a rodeo, that is. Now, what I would rather you not do is please don't send me a book of 500 pages of contract health. If someone could boilerplate that would be great. Break it down to, hey, exactly, hey, this subsection is where it says these are the things, these are the risky things that you're talking about here that are not covered. Very interesting to me. At some point in time, that has to be a subjective decision. What goes into that? Who decides at what level what went into that decision of placing it in as a risky endeavor under contract health and is not going to be covered? Is that a federal Is that a federal thing? Is that a Cherokee Nation thing? Did we adopt it from somewhere else?
It goes along with the federal rules that come along with that money. Then we took it a step further, and we have a team of medical professionals that, we have rules that say everything that fits into these categories, automatic approval going down the road. But anything that fits outside of that goes to some medical professionals that review that along with Mr. Carey, and then that's when the initial denials happen. Then the appeals process, again, goes back to a medical team to review for the approval or denial at that point. And
Okay.
that's how that process works.
And I can understand most of that, but having a military background, it was, one thing was if you weren't wearing your seatbelt, you are not covered medically, right? So if it doesn't matter if you're in a car wreck that was your fault or not your fault, it didn't matter. The military would say that if you're not wearing your seatbelt and it's proven that you weren't, you're not covered. So on one level, I totally understand where that's going. I would just like to, we need to be able, as council here, we need to be able to tell people what those things are and it not be a subjective decision, because when it gets murky, that's when things get a little dicey and people start to lean on the haves and have-nots and who's making the decisions. If that's in black and white, I would love to see it. Not the 500-page, but the boilerplate of, hey, these things are covered and these things are not. If you're doing this specific thing, then no, you're going to be denied. I mean, that'd be good for everyone to know. I mean, that might need to be, is that posted anywhere in any of our clinics or any of our hospitals that say that tell you if you were coming in and you're in a rodeo and you got your back hurt, you need to go somewhere else?
Well, now, if direct care, we're going to give you. We're going to take care of you. If you show up in the ER, we're going to take care of you. Direct patient care, we're going to take care of you. This is only for that referral or paying the bills for something outside of our system. But
Okay.
even if you're in a rodeo and you get hurt and you come to our ER, we're going to take care of you. So that's the difference there. We don't deny services based on that.
Okay. But if they're in a rodeo in Ponca City and they go to the local ER there, they're going to have a problem.
They're going to have a problem.
That's what people need to know.
Yeah.
All right. Thank you, Chair. Thank you, sir.
Mike?
I think Councilman Kidwell asked pretty much everything I was going to ask. Yeah, I know there's rules. Federal money has federal guidelines, but that's kind of hard. Some of that's a little hard to swallow because, I know quite a few people who do that, and some of them can probably pay their bills, and I guarantee you some of them can't. But that's what they do in life. That's part of their life, doing the rodeo stuff. And I got mixed feelings on that, but I understand. I'm just going to give you more of a, it's not on this, but I have a friend who had some health issues, pretty serious stuff, and he's been outside our health system. He is Cherokee, but he was outside, and they weren't happy with what was going on, and they came to the J Clinic and had nothing but great things to say about a Dr. Parrish. They said they came to our facility and they were more than happy with how they were treated, and said it was way better than they were treated outside back to the west. So I just wanted to give kudos out to that doctor and that clinic, because we don't hear a lot of things like that all the time, and to hear somebody who has something very major going on and saying that we gave better care than, other places that are supposed to be, top-notch in that's a big feather in our hat, and I just wanted you to hear that. So,
Fantastic. I appreciate it, and I will pass that along.
okay, thanks, sir.
Melvina?
Dr. Carey, you was talking about the no coverage. I know the Little League baseball and stuff, they have to buy their insurance, to play. Is there an insurance for people that does risky things like rodeo or something out there that they can get themselves?
That would have to be something that maybe our our patient advocates could look at Marketplace and see if there's a way to help them, but inside of our system,
System,
no. And we
yeah.
don't sell insurance to anyone, and we don't cover
But
that.
that's what I
so,
was saying, that's just
yeah.
the thought, if you're gonna do risky stuff like racing or, you gotta think about it, just like the little kids, when they play baseball, they have, they buy, you have to
Right.
buy insurance for them.
Let's see, Junior?
On also denials, and a lot of them that the people don't turn their claims in within the 72 hours, isn't that a big part of it?
Yes, but we generally, try to help once we receive the claims. So even though that is a rule, we try to do our best, even though we don't get them after earlier than 72 hours, we try to work with them anyway. So that's not typically the reason for denials.
Okay, all right.
Johnny?
Thank you, Mr. Chair. One last thing I just want to bring into my, and I'm going to, and this is a legitimate question. I'm not trying to put you on the spot here. If the answer is, sorry, we can't help, I understand that. This morning, I was told that a good friend of mine, Cherokee at-large citizen, lives in Tulsa, on Saturday was diagnosed with stage 4 colon cancer that has spread to both his liver and his lungs. They have not been seen inside the Cherokee Nation system. What can I tell that person? Can I tell them to go to Hastings? They're in St. Francis now. What do I offer these people? Because I get this routinely. And so I want to know that what I'm telling them is the right thing to do. They're legitimate option.
So it depends, where you're located if you're asking about contract health. If you're not located within the boundaries of our coverage area, then contract health is not going to be eligible for, even if they were in our system, if they lived outside of our boundaries. There are some programs that have Cherokee dollars attached to them, but it's still not eligible because they're outside of our boundaries. There's also, within our boundaries, there's a part that Claremore has oversight of and part that we do when you're talking about inpatient services. Okay, there's a difference between inpatient and outpatient. Being in the hospital, like you're talking about, is inpatient services. So there's still a geographic area that Claremore oversees that money, and there's a geographic area that we oversee that money. But being outside the boundaries, your person is eligible for anything we offer as direct care, but not eligible for referral dollars because they're outside of those boundaries. Does that make sense?
It makes sense, and I think that what you're saying is, sorry.
Well, the thing is that.
I mean, I'm trying to boil it down. I need to be able to answer the question.
Right, so if that person lives in the jurisdiction of the Creek Nation, then those dollars, contract health dollars for that person that was counted, went to the Creek Nation.
Okay.
So they would be eligible to go through contract health or try to through the Creek Nation. But those dollars are tied to your geographical location of where you're located. They don't follow you into a system. So if your person comes into our system, those dollars aren't extracted from over here and put into our system. You only get the dollars for the people who live in that geographical location that you're allotted to, not for every Cherokee citizen in the nation.
Okay, so my answer to them is you need to go talk to the Muskogee tribe and see if they can help you out. Because that's where
If that's where their
the
location
funds
is.
are, his geographical funds are tied to him there.
Yes,
Okay.
yeah.
And what do you think that they're going to say whenever he goes over there? Can you postulate on that at all?
I cannot. Can't tell you yes or no on that. That they run their system completely different than we run our system.
Interesting. All right, thank you, Mr. Chair.
Good luck. Danny?
Dr. Jones, on to Councilor Kidwell's question, the Cherokee Nation has third-party billing, and we do have turned profit since I've been on the council for the last 7 or 8 months. Why, is there a reason why that we can't take that money and help these people that have cancer or these other things, and where we don't have to go through IHS, where geographically it's located? Because, I mean, just like this gentleman, I mean, I mean, here he is on the, probably stage 4, and, you know, I'm not a doctor, but he's probably, you know, hanging on. And I mean, to have to worry about the costs and where they're gonna leave him, you know, maybe as a legislative body, we need to fund more money that way to where we can actually, emergency-wise, and can help people that gets into that boat, is a suggestion. Number 2, when is the last time Contract Health with Stephen Carey has actually been upgraded and we've added more people and more room to their offices?
So to answer your first question, we do not get enough money to run our health system. So that third party from the federal government. So that third party revenue that we generate goes back in to subsidize that deficit. And that allows us to expand services, to buy equipment, to add positions, because all that money is budgeted back. When you guys do your budgets and the chief puts forward his budget, the money that we collect from third party is put back into the budget to allocate for expansions and to pay for existing service lines. Because there's a lot of service lines that are not revenue generating, but we still support those service lines also. So that's where that money goes back into. There's not a bunch of money we can say, okay, throw it over here and we're going to start paying for this. The other question about, we are currently into budget negotiation hearings, I guess, with all of our departments. And we meet with Steve Carey's department this afternoon, so I'll see what he asks for. But we do look at each department, look what your load is, what your caseload is, how many people do you have, what's the number of referrals that each person's having to do per week, do you need more support staff? All those type of things are looked at when we're looking at our budgets for the next year. But they're set a year prior. When you guys approve the budgets, that's where those are set from.
Joe?
Okay, I just need some clarifications. I'll make sure I got this right. So Cherokee Nation, the Contract Health, the money is basically for in-district,
Yes.
okay? IHS gets money, Contract Health, they can go to a cardiologist or whatever, as long as they go through IHS. Is that correct, George?
For inpatient versus outpatient.
Right,
So-
I'm thinking in-district, out-of-district.
But there's a difference between inpatient funds and outpatient
Right.
funds. Outpatient funds, we have compacted the outpatient funds for Claremore. Inpatient funds, they still control their CHSDA or their geographic location.
Okay, and then the CREEP money, the federal money, you said if you're, like, Counselor Kidwell's in St. Francis, his guy, then he has to go through Creek Nation, correct?
Yes.
But he could go through IHS.
It depends if Creek Nation has compacted those funds or not. I don't know if they have or not. I don't know the
Yeah.
answer to that.
That would depend on where you live.
So see there's all different variables here.
Yeah. And it's different, it's a different according to how the tribes have taken that. You know, if the Creek Nation has compacted that money, then they control it. If they have not compacted it, then IHS would still control it. And it would
Right.
be the Oklahoma City area, right? Yep.
So if the guy went to the hospital 72 hours, he hasn't reached out to you yet because he's obviously in the hospital. What would the circumstance be for him with cancer? Could he write to you guys to have you guys pay through IHS if Creek doesn't pick it up?
No.
Why not?
Because all that money went to Creek. Creek took all that inpatient money.
Okay, so there is a possibility for the federal funding that's going to you to get shifted to Cherokee Nation for you to do an in-district and maybe an out-of-district to start a program to take care of that.
No. The answer to that is no, because inpatient, if we were to compact inpatient, then we would control in-district.
Right.
But once your geographical location is what ties you to that money. So if
Right.
they live outside of our district or outside of where that boundary is, then that money, whether it's federal money or not, went to the Creek Nation.
Okay.
So that person would have to appeal their claims through the Creek Nation, and I can't speak to what their process is.
Right.
They may pay it, or they may require additional information. I don't know what their process is. But
So that's where
it
we
goes.
have an issue because.
And it doesn't matter what tribe it is, it's done by by tribal citizen, federally recognized
Yeah.
tribes, geographic location of where you live.
Yeah, where you live, so I get that. Because his guy's in Broken Arrow, I had one that lived 3 houses outside the district, couldn't get services.
Right.
So she literally said, I guess I have to wait 6 months. I'll go buy an apartment and then reapply for it, for the health. Because it was cancer again, and then we get the same answers, it's cancer, we can't pay for it because you live 2 houses over. I mean, I get that hardline stuff, but there has to be an alternative way to do it with the federal funding, whether it goes in here or goes to you or goes to him. But that's something I think we need to look at, because obviously the whole point is we say we take care of people, and we hear it from Hastings, we hear it from IHS. But at the end of the day, we wouldn't have so many complaints if they were getting taken care of. So I think that's something we have to look at as a council to take care of people. Because I know maybe even over there where Councilor Sean and Josh are, right over Arkansas, there could be right across the bridge, same issue. Thing is, at the end of the day, they're still Cherokee, but there has to be a way we can fix this problem with health, because it is a problem. Contract health is a huge issue, whether it's with IHS or wherever the money's coming from. So that's what I'm looking at. How can we solve that? And I think that's what Kidwell wants to do with his person that has cancer. Because we've been told, well, they can't cover it. Is cancer not Cherokee? I mean, we've heard this before. But there has to be a way to cover it. I mean, expand the health system, figure out how we can do inpatient, outpatient, those different things. So that's why I was trying to clarify. So, but we'll keep looking into that. So thank you. Thank you, Chair.
Sean? Then Johnny.
On that, Joe, where would the boundaries end?
Yeah.
Just like what you're talking, I mean, would it expand United States wide, or what are you talking?
I think, we just gotta look at the overall picture on where it is, I mean, obviously, looking on care, and there's gonna be hot spots where we can't get them care. Like
Right.
California's a hot spot. Dallas, Kansas City's a hot spot for Cherokees. You know what I'm saying? I mean, I get the whole geographical thing and being in district, but there has to be a way to help those people somewhat, something to offset that hardship.
Thank you, Chair. Thank you, Joe.
Johnny?
Thank you, Dr. Jones. I promise you I'm almost done. I really am. But these points, I've got a real quick question. Number one, I understand the need will always be greater than the resource. It doesn't matter how many we try to get to today, there will be somebody that's not upset or someone that's been denied. I totally understand all that. My question would be this: when we talk about the Muskogee Nation, do we have an official MOU with them that says that we will look out for your people that are living on our reservation land if you're going to look out for our people living on your reservation land? And we can do that onesie twosie. You've seen 3 of our people. It's formally recognized that we're going to see 3 of yours. For every one that you see of ours, we're going to see that many of yours. Do we have an official, government-to-government relationship, memorandum of agreement with them or with any other tribe that says, we will look out for yours that are living here if you will look out for ours that are living there?
So the answer is directly no, but the rules are anyone that's a federally recognized tribe, meaning any tribe in the United States that comes to us for direct services, are eligible. So we see a lot of Creek Nation members coming into, say, Three Rivers, because we're right on the border, and we treat them the same as we treat everybody else. The only exclusion to that is Cherokee-only programs or contract health dollars, depending on where they live. Now, if they live in our district, we got the money for them, so we pay for that. If they live outside of our district, then we do not. Cherokee-only programs are for Cherokees only. So that's the exclusion there. If we have patients that go to their facility that are Cherokee that live around them, they are obligated to see those patients because it's a member of a federally recognized tribe. So there's no MOU needed for that. But I think what you're getting at is for contract health dollars. And that's the part that gets real sticky on where a person lives, because that's where the money is allocated.
Yeah, I'm with you. I think that in theory, sure, all of that should work, but in practice, it's not, right? It's not, because we're having this conversation right now. And I know, obviously, I know this isn't in your house, but burial assistance would be the same way, right? Yeah, somebody at large living in Tulsa that living on Muskogee land needs the burial assistance, which is a federally funded program. But the Cherokee citizens get put at the bottom of the list because every tribe wants to look out for their own. An MOU, an official MOU that says that, yeah, hey, yeah, I get it, federally funded, yeah, we're gonna do the best we can here and try to get to everybody, but I mean, like, really sit down and hammer this out with other tribes. If we did that with every other tribe here in Oklahoma, think of the amount of Cherokees that could be seen by other tribal facilities without such a hassle, right? Without this problem. It seems to me like some type of a practical, working, operational MOU, something that we truly sit down and hammer out. Government to government would be beneficial in this circumstance. I'm just spitballing here, and I'll yield here back to the chair, but man, it just seems like there's some way to fix this. I don't know how, but I've seen this done. I know it's out there. I know it's available, and we should grab it and try to maneuver it and manipulate it and apply it to our circumstances as best we can.
Let me tell you that works both ways, and I'll give you an example. We have a cardiologist that we send over to Three Rivers. We see a lot of Creek Nation patients because they don't have cardiology offered in their clinics. Those patients may need additional services. If they're Cherokee, we have Cherokee programs that we can help the Cherokee patients. We send those patients back to the contract health program for the Creek Nation, and we are at their mercy until that patient can get the service that they need for the referral. And that's a contention that our cardiologist has because they're trying to treat patients. So that works both ways. Once you start down that road, you are also going to have an influx the other way that may deny access, limited access to some of our patients within our districts, or some of our patients that may not be able to get in because we have a limited capacity. We can only see so many patients in a day. And we are doing everything we can to open that access in every way possible at every one of our clinics. That's one of the things that the chief has challenged me with, is to open up access everywhere, and we are doing that at the best of our ability. But at the end of the day, there are only so many appointments that we can see. So, with all due respect, I understand where you're going at, but please look at it from both sides. There's a lot of challenges when you start going down those roads.
Mike.
Well, I have a couple of questions or an observation. What is our budget for Cherokee Nation Contract Health? Do you know what that budget is for that?
I don't know it off the top of my head, but I can get it for you. It's changed because we had some additional monies that came in for things, and through the COVID money and some things like that. So that budget has fluctuated up and down. There are some things that are attributed to it that have reduced the balance, but I do know that we are in pretty good shape compared to where we've been in the past years.
Okay. Do we have a budget money that we give Indian Health Services? Do we give them contract health money?
No, the money comes to us. We've compacted that money, and it comes directly to us for outpatient contract health services.
Through IHS?
Yes.
Okay.
The only piece that we don't get is the inpatient piece that lies within the Claremore service unit.
Okay. Kind of switching gears. I've been here for almost 5 years, and the one thing that I've seen about the Cherokee Nation and its programs, and especially through our Cherokee Nation businesses, is that everybody seems to think that we have unlimited supply of money, and we don't. I know that, people are saying, well, you've got this money, you've got all this money, but the reason we are successful is we do have a limit on what we spend, and we put everything else back into the machine to keep the machine going and keep it oiled, whether that's Cherokee Nation businesses, whether that's, and then we use that allocated money. All these wonderful programs that we do, career services, everything that we do are funded by those monies. It's, if it was as simple as just being healthcare, and it's not, healthcare's not simple. There just millions of dollars, but you're the same way. I mean, the money that we bring in, we can only use X amount of money. We have to keep that going because, you're talking just in the 14 counties. I had asked last year how many people came through in December through our contract health, and it was over 7,000 people were through the system in 1 month. That's a lot of money. So, I know there has to be a hard line, there has to be rules, but, we have ran a system that has worked very well. And to look at it, yes, we can look at it, but there's a lot smarter guys than me who are saying, hey, we're getting to the point where, if we take away from Peter to pay Paul, how are we going to fund this when we take this money from here? And I think that's where we are with our Cherokee Nation businesses too, is, we are so, they fund so many things. If you take away from one, another's going to hurt. So, and I think it would kind of be the same way in this system. You guys have been successful, and yes, we can look at expanding that, but the money that we spend is, I hate to say astronomical, but it is millions and millions. So finding that extra, I think it'll be difficult, but it does need to be looked at. But I think we need to realize that it's been successful for a reason. So that's all I have to say.
And in your report, it shows the projection for this year based on where we're at. We're projected out to spend $42.2 million this year on contract health alone.
Yes.
So that's gives you an idea of where we're at right now in projections.
All right. Thanks, sir.
If I may, Dr. Gann and Ms. Pivak will be with you just shortly. You might have, counselors, you might have noticed for discussion, we were going to talk about Cherokee Nation contract health. Seemed like we already drifted into that. So we'll just go ahead and wrap it up here. I know, Danny, did you?
Yeah, Dr. Jones, someone's asked questions. Somebody said we look at 12,000 contract health referrals per month. Is that probably in a roundabout? So that would be on a 12-month year. That'd be 144,000 referrals. And I kind of laughed and chuckled and said, well, we only have approximately 135,000 within the reservation. So we're seeing 144,000 referrals for different things throughout the 7,000 square mile reservation.
We're seeing a lot. I don't know that number off the top of my head, but I can get that for you. The one thing that we have to consider, and this is something that everyone, when we look at adding services or adding providers or expanding services, for every provider that we add, we know that there's a metric that's going to go along with contract health, because there's going to be a certain amount of things that provider is going to find that are not going to be treatable in our system. So as we expand services, there's also that factor that we have to exponentially factor in for the amount of contract health that's going to have to be added to the budget to support each one of those providers we add. Because we don't do everything, but we do know that there are a number that we've kind of come up with through a formula of an estimate of how many referrals each provider is going to generate. So when we talk about adding services and spending our revenue to add another service, let's say we add a doc, we got to add nurses, we got to add patient services out front, we've got to add support in the lab, we've got to add a lot of things to support that one provider, and contract health is another piece of that support that we always have to factor in as we are expanding our health system.
Thank you.
Anybody else for Dr. Jones? I might mention too, I left a 15-page or 14-page report that Mr. Carey's put together on contract health. You might keep it handy. When questions come up, just look through this report. There may be some answers to your question. I found interesting, too, the map that's in your report. It tells you if the patient's referred for outpatient care versus inpatient care. For example, if we have a loved one that goes to Hastings and the ER sends them by ambulance, St. Francis, and they live, let's say, in, well, let's just say Muskogee, but in the 14 county. If they check in, if they're inpatient, then they, all of a sudden, they're under creek as far as contract health. But if they go there and they don't admit them and they come back, then they're still under Cherokee Nation contract health, right? Dr. Jones?
Yes, depending on where they lived, yes.
Yeah, right. I meant the Muskogee citizen if they. So you see, if you have a family or a constituent that goes by ambulance, do we pay for the ambulance ride, Cherokee Nation?
Typically, yes.
Okay,
Typically, yes. There are some exceptions to the rules, but typically, yes.
Because I get all the questions about ambulance rides, and they get a bill for the ambulance ride, and they don't understand, and so I didn't know exactly what.
And some of that is because they don't know where it's in the bill.
Yeah.
All they have is what's registered into the patient's file when they showed up to the ER.
Okay, all right. But anyway, I'd encourage counselors to look at this map, because I think that I have to look at it every time a constituent calls me. I ask them two questions. Well, were you admitted, and where do you live? And that helps me determine who to check with or to help them with. So that those two maps are for me anyway, they're very helpful. Any other questions for Dr. Jones? I think he's getting tired. Thank you, Dr. Jones.
You're welcome. Thank you.
Good afternoon. In the interest of time, I will try to be quick. It's good to see all of you today. You have my report, or our report, in front of you. A couple of things I'd like to highlight. One is that the new website for Cherokee Public Health did launch. It's CherokeePublicHealth.org. You can also get to that from Cherokee.org, or you can go straight to CherokeePublicHealth.org. So we are building more into that website as we speak, putting more things on there to make it more convenient for citizens. And there's one particular piece of it, which is being able for communities to be able to look at the data source that's on there, put in different parameters, and use that for if they were doing community grants, if they're just interested in what their county looks like. It is fueled with some publicly available data as well as proprietary, and we are working right now to safely put the Cherokee-specific data on that website as well. So encourage you to look at that. That is also where our tribal health assessment should be uploaded within the next week or so. It is finished. We have just a couple more edits to do to it, and maybe a little one more change, and then it'll be on that website for your review, and everyone else, the public's review. We'll also have some printed copies that we can bring. The other thing that I wanted to mention today, just I had anticipated I might get a lot of questions, but since we're running low on time, probably don't have those, but make sure that you know that we are keenly aware of the infant formula shortage that's going on. We're working really hard with USDA. We got a letter on Friday from USDA on the waivers that we can file for WIC. Special things that we can do to try to get formula for our WIC participants. Also working today, I had a call from some of the emergency room staff that have mothers and families coming in with a shortage. This is a nationwide shortage. I believe the stock as the close of last week was down 43% on the shelves. Abbott, who is the plant that closed, accounts for 40% of infant formula that's made in the United States. So a lot of the biggest issues that we're having right now are finding the specialty formulas. So our WIC staff are working to go to any place they can to find that specialty formula for a WIC participant, also getting them in touch with a pediatrician to find a suitable other formula. A multitude of things that we're working on right now with that. And if you have any questions, be happy to answer those. One of the important things that I wanted to get while we were on camera is to make sure that families out there know that they should be very careful in purchasing anything off the internet or the web, online purchasing. As you can imagine, there's lots of scams going on out there, and you want to make sure that formula is safe and that it's reasonably priced and that it is what they say it's going to be, or that you're actually going to get it. Because with a shortage of this magnitude, every state's impacted right now. And also, we're advising against certain risky practices. Families should not make their own homemade infant formula, nor provide cow's milk before the age of 1. These are unsafe nutrition practices for infants. If you have any questions about any of that, anybody out there, they can contact our WIC program. Whether they're a participant or not, we can give them information and get them up to date, and hopefully our WIC staff might be able to direct them to find the particular formula they might be looking for. Other than that, I know I had a question last time about summer EBT, and happy to inform you that the WIC director managed to get another $25 fruit and vegetables, so that's now up to $55 per child each month for the SEBTC. So, do you have any questions? If not, I can pass it off to Dr. Dan.
Any questions for Ms. Pivek or Dr. Gann? He's back there as well. Is Dr. Gann, you going to make a report as well? Okay, I'm sorry. Anything else, Lisa? Thank you.
Thank you.
Please. No, Dr. Gann.
Thank you, Mr. Chair. I just want to give you a quick COVID update like I've been doing for the last 2 years. So globally, numbers are pretty steady, about a half million cases a day, but there are 7 or 8 countries that are having significant surges: Japan, Taiwan, Australia. Europe is mostly in the red now as well. Now, in the United States, we're getting about 100,000 cases a day, about 2,700 new hospitalizations every day. The data quality overall is becoming a little less reliable. A lot of people are getting sick and not getting tested for COVID, or they're getting tested at home, and so they're not accounted for. We also know that a lot of people being hospitalized aren't being hospitalized because of severe COVID. It's an incidental finding for another hospitalization. So some of the predictions or estimates on what's happening, the number of cases, are just insane, and they're just not really based on good science. So for us to make good predictions and give advice for the future here at Cherokee Nation, it's very difficult, but we're working, keeping an eye on the science to see what's going on. At Cherokee Nation, we're sitting at about 10 cases per day on average, which is up from last time we met, we're about 2. So it's going up very slowly. Same way in Oklahoma, averaging 150 cases a day in Oklahoma. I'm confident with the numbers we have at Cherokee Nation Health Services, because testing is very simple, easy for our population. So I think a lot more people get tested. The hospitalizations at Hastings are rare. So hospitalizations are staying low, but the viral activity is picking up. In the U.S., it's about 50% of the BA1 variant, and the other 50% is the BA 2.12.1, right? And we know that each new variant that's taking over is more contagious than the previous one. So what everyone's concerned about is the next variant that comes along, if it spreads more easily, is it going to hurt people more? So there's a BA4 and BA5, which is going on in South Africa, that they're studying now. We don't know about that yet. So cases are going up very slowly, and I expected them to go up more quickly when we got to this level again, but they're not. So there's some immunity out there. The studies are showing us that with the newest variant, the BA 2.12.1, that's becoming predominant, that prior infection provides very little protection from getting infected again, and that if your immunizations are old, it doesn't provide a lot of protection from getting COVID, but still some protection against hospitalization and severe illness and death. So I say some protection from hospitalization, it's like 80% compared to not being vaccinated, but it was 90%, so it's going down. So it's all very concerning. Know that the public health team is tracking this on a daily basis, and no red flags to raise today, but we're keeping an eye on things and keeping in touch with the science. Any questions?
Mike?
I was reading, or actually, I watched a video of a guy in the government urging them they were low on COVID vaccines or whatever for the, and they think there's going to be a surge coming and the United States isn't going to have enough vaccines to cover everybody who's going to need them. In regards to us, I suppose there's a shelf life for some of those. I know that some that had to be refrigerated, I mean, at a certain really, really cold temperature. What is our status on vaccines that we have?
I don't keep track of the vaccines, but we don't have a shortage.
Okay.
So, yeah, we've got a good supply of vaccines. Uptake recently isn't that tremendous.
Okay.
Yeah, so that's.
Well, I know they were kind of panicking about it in the federal government.
Yeah,
so,
sure.
Yeah, all right, thank you.
You know, what would be the situation where the people who aren't vaccinated now are going to say, I want to be vaccinated? And I don't know what that is.
Thanks, sir.
Yep.
Any other questions for Dr. Gann? Okay, thank you, Dr. Gann.
Thank you.
Appreciate it. Thank you for your report. Okay, moving down, old business, none. Whether you realize it or not, we took care of new business. And any announcements? I have one announcement. The OU College of Dentistry is opening a second campus at the Schusterman Center in Tulsa somewhere around June 1st. They'll be having a ribbon cutting there, but that puts a dental school within really close to our reservation. So I thought that was an interesting information to pass along to the counselors. Uh-huh.
I'd like to congratulate Dr. Jones's son for just graduating OU dentistry program.
That's right, Dr. White Jones. Yeah, he just congratulated him. Yeah, anybody gets out of dental school deserves that. Okay, I need one more motion. Second. Okay, meeting is adjourned.